happy to say that I've been in communication with Dr. Levine. You know, I have I've emailed her a paper that was talking about instead of R naught, there's a P naught, which is progression to zero. Okay, and progression to zero is a very hopeful metric. It's not a daily. This is how many people died, and this is how many new cases there are. It's I suggested that they transition to a progression to zero, where every county has a 7-day moving average of how close they are to zero new cases and zero new deaths. And so, yes, they're there. They're willing to listen, and especially the ones that are not seriously overburdened right now. I mean, there's the doctor in Lincoln, Nebraska. There's others that I'm communicating with and saying, there's a Dr. Lisa Sanchez that is trying to get a grip on her metrics out in Arizona. And so she's saying, patients are coming in from this zip code, they're getting admitted in this zip code, and where they tested positive and the case counts are all a mess because the data is not appropriately reported and appropriately curated and all this other stuff. So, but back to the point that you were making is, can we now re-engineer our approach to this on a community to community basis, and will that have benefits? Because clearly it will. I mean, just clearly, what I was talking about a couple of weeks ago here was green, red, yellow. Okay, if your community's been green in terms of its population density and transmission, then you should be able to live differently than a community that is under a great deal of risk. But the only way to assess that is with testing. Okay, it's not guesswork; it's testing. And then we had a lot of questions a few weeks ago. Wow, you can't test everybody every day. Yes, you're right. You can't. So you do it by their exposure to risk. If you're Dr. JJ Racimus and you're going to a hospital every day, you should have the opportunity, if you're definitely going to be, in exposure, getting tested twice a week. If you're living on 144 acres and your entire social bubble is 7 people and a horse, you can get tested a month from now and then 3 months later. But at least put yourself in the data pool, please. You know what I mean? Like, your negative result is as important in Nowhere, Nebraska, as it is in Wilkes-Barre, Pennsylvania. I want to know you're negative in Wilkes-Barre, Pennsylvania, and I eventually want to know that you're negative in Nebraska too. But where the risk is highest, we're not telling people that.
But the important question we have to ask is, how often does the horse have to get tested? And with that, we need to take a quick break. We've mentioned Dr. Rachel Levine a couple times. Every week I play this clip, so I'm going to do it again now. This is Dr. Rachel Levine, our good friend, the Pennsylvania Physician General and Secretary of Health.
Thank you.
Now, here are my daily reminders. Please wash your hands with soap and water for at least 20 seconds, or the time it takes to sing happy birthday twice. Use hand sanitizer if soap and water are not available. Cover any coughs or sneezes with your elbow, not with your hands, and try not to touch your face, especially at touching surfaces. Clean surfaces frequently. And if you are going out for life-sustaining activities, please wear a mask if you're going to come in contact with others. Practicing these everyday prevention measures can help slow the spread of the dangerous virus, COVID-19.
I want to thank Sanjay. Just a side note, you had mentioned some of the folks who were saying some not so nice things about our friend Dr. Levine, and so thank you for bringing that up, and hopefully you're in a good conversation with Rachel and Sarah over at the Department of Health. I've worked with them for many years and happy to have been able to help you connect with them. So hopefully they listen.
Yes.
And
Yeah. I'll keep checking with them. You know, there's our resource page, and I hope for them to take some time once in a while to follow. Like I said, we've now segmented our resource page into the page, which is really directed towards people not in the healthcare community directly. And then we have the resource group, which is people who are really interested in observing what's going on in the scientific and biomedical community. So that's where I'm posting the papers and things like that. And that's where I will continue to send her team and let, you know, it's curated by me and others with commentary from, as you know, doctors across the world. So we'll get into that later. But let's get back to the conversation, if we could. Let's catch up on questions or comments if we can. Karen, do you have a summary, or should we just kind of read off the group chat? I'll let you do it, Karen.
I don't have any specific questions for the doctor in the chat, but do people have any right now that they might want to unmic and ask?
Yes, great idea. Let's do that.
Yeah, I'd love to be able to take the balance of our time to have direct dialogue about really some specific questions if they're really more pointy. Because we've been talking in broad strokes and these themes have been really great. But if folks have specific things they want to comment on and ask about, that would be really great.
And if people are watching through the Facebook Live, feel free to post your questions there. I've also included a link on the Facebook Live if you'd like to join the conversation through the Zoom interface and join us with a webcam or a phone live. You certainly can do that. I have a quick question. I have a question that to get us started, and that is, let me find it here. So looking on the brighter side of things, maybe, obviously mental health, healthcare has had to really reinvent how we do things during this. You had mentioned people talking, JJ, you had mentioned people talking on an iPad or whatever. Do you think, if we think longer term, that some of these accelerated technology solutions will help over the overall mental health of the world?
I do think so, John. I am optimistic that way. And I have to confess that psychiatry as a discipline has been reluctant to be customer service focused, when in reality, large portions of our society have been begging those of us in mental health to become more flexible in the way that we deliver ourselves to be helpful to the society that we serve. And now, frankly, the pandemic has forced us to embrace things that folks have been begging for us to think about for a long time. I talk to my psychiatry colleagues and therapy colleagues regularly, and they say, no, whether we really get a handle on the coronavirus and can go back to something completely normal, I can bunny ear the heck out of this all day long. But the idea is, we're never going to go completely back to the way that we delivered our care in our specialty of medicine, and really in any other. There are always going to be folks now who say, I got my therapy during COVID via telemedicine, and I really found that convenience was much better because, frankly, going across town when I've got kids to take care of and 15 balls to juggle in my life, it serves me better to be able to meet with my therapist for 1 hour without that having to take me 3 hours total in order to engage with the treatment, because I can do it where I am, and I want my therapist to meet me where I am. And so meeting people where they are in their struggles during this time actually should generalize in a way that we're going to deliver treatments better. So, there had already been designs on mental health apps to be able to not only support people, but also gather data that then doctors could use to assess symptoms over time and provide care and respond more quickly without having people have to come into the office or wait for the next available appointment, which those of you who either have mental health conditions or know someone who's got one, it takes months just to be able to get in the door with a psychiatrist in a clinic. Yeah. Well, That actually is not the way that it is now. Access, although it's not the same kind of access, in some ways has actually increased. It's become better. And we have psychiatrists saying, you know what, this is a crisis. I owe it to my patients to reach out to them. Now they're making more phone calls, they're checking in, and they're actually having more encounters with their patients than they did before. Paradoxically, some things have actually improved. We just need to be flexible to realize that we could do that at many levels. We could do it at the psychiatrist level, the therapist level, but also the social worker level, the case manager level, the community organizer level,
Yeah.
the psychosocial treatments that are group-based rather than individual. We all could be working at that different level to be able to have more contacts rather than sitting around saying, oh, I don't like the no-show rate in my clinic. How am I going to fix this? You fix it by picking up the phone.
Yeah.
Really. So there are absolutely opportunities baked into this crisis. There really are.
So John,